weather. So if for some reason I warned Dr. Hoffman that if I get cut off, she'll jump right in. But we're gonna get started here soon. Please put your questions in the chat. We're gonna be going through those at the end of her talk. Very excited to have you with us, Dr. Hoffman. How are you?
I'm well. It's exciting to be here talking about one of my favorite topics.
I know, I can't wait. Just got another minute or so before we start. I want to thank Gail Wiley, who's the president of Aspire Products. She hosts these Wednesday webinars. We usually have these every last Wednesday of the month. I have the honor of moderating different experts in different fields within our discipline of speech language pathology. We've also been incorporating some talks from the respiratory therapy field as well as the physical therapy field. I think I will formally get started here tonight with Dr. Bari Hoffman. Bari is a close friend and a great colleague. We've known each other for a long time. She's going to talk to us tonight on atrophy in the airway, management of aging and unique populations. And Bari, it's just been great to see your career soaring as a leader, not only in speech pathology, but in healthcare innovation, everything that you're doing now with simulation and artificial intelligence and your work with so many different unique technologies and how you're integrating them into the healthcare system. And I'm just really glad to have you on. As an Associate Dean of Clinical Affairs, she's at the University of Central Florida. As you can see from her title slide, she's also Professor of Internal Medicine. And of course, her primary appointment is Professor of Communication Sciences and Disorders at University of Central Florida. I don't want to date you, but how long have you been at UCF now?
23 years.
23 years. Looks like it was just yesterday. So I'm love to hand the microphone off to you, and then I'll chime back in during the Q&A. Thanks again for being here. We appreciate you.
Thank you. And thank you to Gail and Kim and Chris and the whole Aspire team for inviting me to talk on this topic. I'm coming to you from Orlando. And so when you think of Orlando, you think quite a bit about the picture on the left, the theme parks that are here. But I'm literally sitting in the building on the right-hand side, looking out the window and with you in view from our campus in East Orlando. I spent my entire academic career here at the University of Central Florida, as well as within a large ear, nose, and throat clinical practice where I ran a very busy voice and upper airway center, a voice and swallowing center. So I want to just kind of touch base a little bit on my background and why I'm sharing some of the content I am today. As Chris had mentioned, my affiliation, I really wanted to talk a little bit about my clinical practice and research, which is focused on respiratory muscle strength and its impact on the upper airway system, both in normal and disordered functions of the larynx. So I was fortunate to have been a student in Dr. Sapienza's lab in the mid to late 1990s, when some of the very first studies on respiratory muscle strength training were being conducted and data collection was ongoing. And the device was being developed. And there was a fairly significant team, respiratory physiologists and physical therapists, and a large number of other colleagues that we've been working with and together across about a 25-year history, both in the area of the empirical science and the translation to clinical care. And I think that's really where my role really peaked in this team, is integrating some of the first clinical studies and integrating into our voice and swallowing clinic here in Orlando about 22, 23 years ago. So we have worked together through the design of respiratory devices and utilized this training paradigm in the assessment and the intervention with a wide variety of patient populations. But we have also used it prophylactically for those who are aging. And we're going to spend quite a bit of time talking about that tonight. So as a clinician and physiologist, I have been studying symptom prevention for functions associated with breathing and functions associated with swallow and cough, airway management, speech, and voice. And so tonight, it's really my pleasure to share just a little snapshot of this work with you. So I want to just touch on just a broad thinking of aging. And you know, what we know about aging is, as a society, we're really starting to age well, with a focus on wellness and well-being. But that's really going to be putting a lot more pressure on us as clinicians to be working more in terms of our rehabilitative strategies. And so for just a minute, I just want to ask you to sit back and reflect on someone you know, someone close to you, who is older, and reflect a little bit on what you see changing in their bodies. So this is actually a picture of my mother. And this picture was taken about 5 years ago, and we had just celebrated her 75th birthday on a cruise to Alaska. And so I was watching her keeping up with technology with her iPhone and her iPad, and even electronic bingo daily on that cruise. So our aging population is keeping up well with some of the trends in technology, but our body systems are still deteriorating. And over the past 5 years, I've seen a really sharp impact and decline of my mother's functions and some of her functions associated with the upper airway and air digestive functions. So we have to figure out how to catch up and rehabilitate individuals and combat the effects of the deteriorating skeletal muscles and the degenerating joint and organ systems to help them keep up, because we're not just dealing with individuals who are in their 60s and 70s anymore. We see patients, or we see healthy individuals who are living well in their 80s and their 90s, and we see that they can be very functional at this age. And we want them to be able to eat well. We want them to be able to be physically active, be able to move their bodies, and not have deficits in their breathing function. So we have to consider having individuals train on these devices in a prophylactic manner to exercise muscles of swallowing and the muscles of breathing and speech and voice. So this whole area of aging, I think, has really become a heightened focus. In fact, some of my work in technology is in aging in place and age tech. So as clinicians, we need to be thinking about prescribing strength training paradigms for healthy individuals. And so that is my soapbox moment. I'm going to jump into a little more details of this presentation, talking a little bit about the age-related changes that we recognize in the respiratory and laryngeal mechanism. We'll briefly touch on the high burden of upper airway disorders economically. We'll look at some of the typical symptom profiles and the physiological basis across voice, breathing, cough, and swallow, and a little sample of some cases highlighting why respiratory muscle strength training was selected as an intervention strategy, or as part of an intervention program for individuals in aging who have voice, speech, and swallowing deficits. So let's talk just a little bit about the burden of upper airways disorders. There is a significantly high burden, particularly in the United States. It's estimated that about 5.2 million patients with upper airway disorders seek treatment annually. And this translates to a total direct healthcare cost of about $13.5 billion. And so when you look at that number, it's quite comparable to the dollars spent on conditions like COPD and asthma, diabetes, and allergic rhinitis. So upper airway disorders are even more prevalent in individuals as we age, placing an even higher risk for lung infection due to poor airway protection associated with reduced vocal fold closure and a weak cough. And we know a significant deterioration of quality of life has been recognized in patients, where we hear anecdotal comments about individuals experiencing social isolation, depression, and anxiety. I also want to highlight that dysphonia in particular is also a tip-off to other underlying disease processes, other things that can be age-related that are occurring in other body systems. So I want to cover just a little bit of a review of some of the age-related impacts in the respiratory and laryngeal anatomy. We know that aging causes general changes to all systems in the body, And in particular, we're going to focus on the changes that occur in the skeletal muscular system. Some of the same changes that can occur due to age, muscle disuse, that occurs in the limb muscles can also occur in the muscles of respiration and the muscles of voicing and muscles of swallowing. So those same structural changes can cause fatigue and reduce the contractile forces and capability of those muscles. And more evidence is suggesting a marked vocal fold atrophy and in particular vocal fold edema. So we're going to dive into some examples of that in just a moment. But before we do that, I want to spend a little bit of time talking about why we're focusing on respiratory muscle strength, particularly in the mature individual. As you know, the respiratory muscles are skeletal muscles, just like your limbs, as we were mentioning. And we know that with age, those muscles lose their strength and they lose their force and they lose endurance. And so we refer to the term sarcopenia as some of those age-related loss of muscle strength seen and has widely been studied in the physiology literature. This has been demonstrated in studies depicting reduced strength of the expiratory muscles, along with reductions in lung elastic recoil and chest wall compliance. Taken together, this really can decrease the expiratory flow rates and airflow velocity, and is really further exacerbated in individuals who experience a sedentary lifestyle and lack of physical exercise. It's also important to recognize that in general, the older population has less pulmonary reserve, they have less cough strength, and decreased pliability of the thoracic cavity. This reduced pliability of the lungs and ciliary dysfunction impacts airway clearance. And so in a study by Bodish in 2018, coming out of CHEST, their study reflected on the prevalence of lung conditions such as chronic obstructive pulmonary disease and pulmonary fibrosis, and that the lung infections such as pneumonia increased sharply with age. And so the physiologic, cellular, and immunologic changes that occur during aging contribute to the development of lung disease. So these studies are highlighting that age-related changes in physiology and function are not just key to preventing or ameliorating disease, they are essential for understanding healthy aging. So highlighted here on this slide is a picture of vocal folds on the left-hand side, and what we typically see under laryngoendoscopy for an individual, anywhere from age 65 to 80, 90 years of age. And the typical findings upon laryngoscopic examination show atrophic bowed vocal folds. And I'll play this video. There's just a little bit of sound. You'll recognize the lack of glottic closure, which causes more of a breathy voice quality, bowed vocal folds, and some prominences along the vocal process, which is not vocal pathology. It's a more prominent cartilaginous appearance. So largely, some of these age-related changes that we see in the vocal folds, are associated with calcification of the hyaline cartilages, decreased mucosal secretions, decreased neuromotor control. We see mucosal atrophy and changes in the components of the lamina propria. This can be partly associated with an increased number of collagen fibers and a decrease in the elastic fibers. Also, a decrease in hyaluronic acid results in some of the muscle atrophy that has been observed. Here's another picture depicting laryngeal findings where we see essentially a thinning of the vocal folds. But what appears to be a sulcus is really what we see as a pseudosulcus. So vocal fold bowing, prominences of the vocal processes, which are very evident in this example, a wider glottic proportion. Under laryngoendoscopy, what you saw in the previous video, you would have recognized phase amplitude and symmetry of the mucosal wave is altered. Oftentimes at rest, we might see tremor of laryngeal structures, particularly along the posterior aspect of the glottis, and also laryngeal sicca or excessive drying of the mucosa. Collectively, you probably have heard the term presbylaryngis or presbylarynx. This is just the term used to refer to changes in the larynx associated with aging. So this is another common finding under laryngeal endoscopy. In the piriform sinus, we will see poor secretion management. So this is an image depicting frothy secretions along the piriform sinus. But what I want to call your attention to is the high risk of aspiration or trace aspiration when negative pressures from an inhalation occur and can result in aspiration of secretions and lead to lung infection. As we know, the secretions in the oral cavity are laden with bacteria, and oftentimes it is poor oral hygiene that can lead to the increased risk of aspiration. I'm sorry, of pneumonia because of the aspiration of secretions. So what we're commonly treating are dysphonia, dysphagia, dystusia, and dyspnea. And oftentimes our patients present with a combination of these symptoms, and it isn't a simple formula. So we want to kind of highlight the use of interventions such as respiratory muscle strength training as the potential for reversing some of the age-related changes and ameliorating some of the symptoms and a tool for airway protection. We want to try to get in prophylactically and address these changes before a patient becomes symptomatic. So many of you who are on this webinar tonight have at least heard of respiratory muscle strength training, are using it. Maybe you are just beginning in your process. Some of you may be expert. So forgive me if I just go through some of the general aspects of this very briefly. For those who are just starting out, respiratory muscle strength training is essentially weightlifting for the muscles of respiration, both your inspiratory muscles and your expiratory muscles. And so, as we mentioned earlier, your respiratory muscles are skeletal muscles which adapt and in response to training. We know that increases in force generation of the muscles that are involved in respiration can also increase the strength of cough, the pressure head required for voice production, and can decrease the perceived work associated with breathing and breath coordination. And there has been a well-developed literature that shows evidence on improving some of the biomechanical events for swallowing. So respiratory muscle strength training is essentially a process for building strength within the muscle groups of respiration. We are targeting the diaphragm and the external intercostal muscles when we are doing inspiratory muscle training. And we are predominantly targeting the rectus abdominis or the abdominal muscles and the internal intercostal muscles when we are doing expiratory muscle strength training. Training can range from a very low threshold, 15 centimeters of water, depending on device, could be a little bit lower, up to about 150 centimeters of water. And patients across the lifespan with both hypofunctional and hyperfunctional laryngeal conditions, as well as neurogenic populations, have been evaluated, treated, and empirically studied. So there is a wide literature base to help show evidence and the treatment intervention and the training protocol. If you have been attending some of these webinars, you've likely seen some images like this. The training is carried out through a device that you see on the left-hand side of the screen. This is an older device, so forgive me, Aspire, for not having an updated image on here. And the typical training protocol is a 5-week program that lasts 5 days per week. 5 weeks, 5 days per week, and 25 breaths per day. We typically train individuals at approximately 75% of their maximal capability of either their maximum inspiratory pressure or their maximum expiratory pressure. The device itself is calibrated. There's a spring-loaded valve. And so you as the clinician can set the training for the week. And that means that the individual who's using it can't vary their breathing load against the device because the valve doesn't work unless the prescribed pressure is achieved. So this is referred to as a pressure threshold device. Essentially, there's a little spring-loaded valve that opens when the calibrated pressure or the prescribed pressure is achieved, and then air flows through the device. So as a clinician, I can tell you is probably one of the it was the easiest training techniques or interventions to have our patients adhere to. And one of the reasons for that is that they were able to tell independently whether they were doing it correctly. It was a tangible device, and that was always very helpful in their adherence and their awareness of their training protocol. It is not a resistance training. This is very different than other devices that are resistive devices because the physiological load in the resistance devices is not calibrated or imposed. And so essentially minimal effort or maximal efforts can vary. These are just a few samples of devices that are out there that are considered respiratory devices. It's really important to know and be aware of device selection and knowing the mechanics of each devices. So the device on the left-hand side, you typically see variations of this provided to individuals, usually right after surgery, to move air through the lungs. And so there isn't a pressure load that is essentially imposed that's going to target strengthening the respiratory muscles. The device in the middle is typically used for resistance training, and the device on the right is a threshold device. So it's important to be aware of the types of devices that you're using and the mechanics of those devices in order for you to appreciate the desired outcome and strength gains through the published training protocol. So enough on the device. I know that's not the focus of today's talk, but I wanted to just highlight those in the context of some of the cases that we're going to be discussing. Some of the typical case histories of patients that we have used respiratory muscle strength training with through the years in clinical practice have included a variety of individuals who have underreduction. That could be somebody with a paralysis or paresis, atrophy, hypotonia. We've worked with individuals who have overadduction and so hyperfunction, and so reducing the load of the larynx or the compensatory behavior of the larynx because they're potentially the respiratory musculature was fatiguing too quickly. We've worked with individuals post-intubation, post-stroke, a whole host of movement disorders, neurodegenerative disease processes, Parkinson's, MS, ALS, myasthenia gravis. You've probably engaged in other webinars, or you can probably look up some of the former webinars that some of these particular populations were highlighted. We're going to talk today about elderly. In particular, we've worked with a lot of individuals who are the sedentary elderly classification. We've worked with performers and instrumentalists, individuals who have had blunt trauma to the head and neck. We've worked with a whole host of head and neck cancer patients, individuals who have hyperfunction and muscle tension related dysphonia. We've worked with athletes and a whole host of other individuals. So I'm happy to connect with you offline if you're ever considering using this training modality with other populations. Before I get into the cases, I like to use this hierarchy to sort of talk about where does respiratory muscle strength training fit in the task hierarchy, in particular for dysphonia and dysphasia. And we could even look at this in the context of dysphagia. This same framework works. And, you know, one of the things that we really need to have as sort of baseline is that we realize that it's difficult to accomplish movement and skill without muscle force and strength. So at the very base of this pyramid, we need to ask ourselves as clinicians, does my patient have the appropriate anatomy to complete the desired task? And some examples where this might be no, might be in a case where you have a patient who has glottic insufficiency or palatal insufficiency. And so stepping in with some interventions in the area of voice and respiration may not be appropriate because we need to first address anatomy. And so a referral for augmentation may be another course of action as part of the intervention plan. Another scenario might be somebody who is, poor dentition or no dentition, and we would need to refer that individual out. So once we cover our bases and know that our patient has the base anatomy and functional capacity to perform a task, we can then move up the pyramid. So the next question we want to ask ourselves as clinicians is, does my patient have sufficient strength to perform the task safely? And for many patients, the answer would be no. That's why they've been referred to you. So either strength training or coordination or combination of these are disrupted. And so your goal at this level of the pyramid is to increase their strength. So really any technique that applies the principles of overload, of repetition, and specificity would apply here. So once we get to that point, in the top part of the pyramid, this is where we want to, and let me just mention that this is in the middle part of this pyramid is where respiratory muscle strength training, holds most value. So in the top part is where we are looking at your patient's ability to skillfully execute the task. And so strength, again, is only one half of the equation. There's also skill and coordination. And this is where tasks with high transference are really best. And so blending this approach to emphasize motor learning is really critical. So I just wanted to kind of highlight this. Oftentimes we need to train both skill and strength, and determining if that can happen together or if one needs to precede the other is really important as we think about that hierarchy. So let me jump into just a few cases in the next 10-15 minutes of time that we have left. And just to highlight a few where we've intervened with respiratory muscle strength training, either solely as the intervention of choice or in combination with a variety of other intervention tasks. And I'm going to focus a little bit more on the voice cases for these first few. This is actually a case of an individual who had vocal fold atrophy. And what you're seeing are some laryngeal examples that are pre-intervention, pre-therapy, and then 4 weeks post voice therapy. We actually published this study where we were carrying out an intervention with forte or phonatory resistance training exercises with and without expiratory muscle strength training. And so what you're going to see here is an 84-year-old male who's otherwise healthy, who had a reduced vocal loudness, who had experienced a weak cough and intermittent throat clearing. And so this individual had a combination of therapy, both voice therapy with forte and with expiratory muscle strength training.
Okay, and breathe. E. And breathe. Good. And breathe. E again. Good. 3 short he.
So a few things that you should be recognizing. One, there's a significant bit of hyperfunction, hypertrophy of the false vocal folds. Significant bowing of the vocal folds. Actually showed you this in a still image earlier. During inspiration, you might notice a little flicker, a little bit of tremor in the posterior aspect of the larynx as well. Just advance this a little bit.
Okay. Okay, and breathe. E. And breathe. Good. And breathe. E again. Good. 3 short he. And breathe. And breathe again. Good. And breathe again.
gives you a good example. So pre-voice therapy, Forte and EMST training, and this is 4 weeks post.
And breathe. E again. And breathe. E again.
So not a perfect example of laryngeal function, but substantially improved in a short bit of time, where we see better glottic closure, reduced hypertrophy of the false vocal folds. You do see some frothy secretions in this particular image. There's still evidence of some tremor, but this just highlights short duration impact. And this individual also had significant increase in their cough strength. So here are some of the images pre and post captured during inspiration and phonation, just depicting some of those laryngoscopic findings. This is another series of individuals who experience underreduction. All three of these patients were 65 years or older. Actually, 2 were in their mid-80s. And they also had other confounding physical findings and comorbidities and health history. So first case is an individual who had vocal fold paralysis and severe glottal incompetence. This patient also had a history of aspiration pneumonia and had some previous complications with anesthesia. Second patient was also a head and neck cancer patient who, due to radiation, had radiation-induced vocal fold paralysis and severe trismus post-radiation. And the third patient is an individual who had a history of Parkinson's disease, severe bowing of the vocal folds, and a history of cardiothoracic problems. And so probably the go-to maybe immediate action that some of our ENT and laryngology colleagues might engage in would be something more surgical or office-based surgical. And all of these individuals, because of their comorbidities, were not able to undergo anesthesia for vocal fold nebulization. So each of these individuals were offered and underwent a office-based vocal fold nebulization technique. And this is just a small video clip for those of you who haven't had a chance to see what these techniques look like. This is actually under endoscopy in the office. What you see is the presentation of the material that is being used to augment the vocal folds to structurally improve glottic closure and reduction in aspiration and improve airway protection. And so this just gives you a sort of sample of that, and you'll see that the vocal folds will bulk up. Initially, they're over medialized, and within a short bit of time, depending on the material that's injected, that material will absorb, and the vocal folds will not be quite as bulked up as they will at the end of this particular video. So now I want to highlight a little bit of the obvious changes that we would presume would occur in voice, but also talk a little bit about cough and cough as an intervention and a corrective function for airway protection. And so in this particular series of patients, we studied their cough pre-office-based injection, immediately after injection. And so what you see highlighted here are some cough measures: cough phase duration, expiratory phase rise time, cough volume acceleration. And there certainly were some improvements in the percentages that we saw across the patients, all 3 patients pre to post. But it wasn't enough to really improve functionality. And so what we decided to do, since the post-injection cough airflows were improved, but still below normal ranges for expiratory phase rise time, we decided to intervene post-injection with expiratory muscle strength training. And our hypothesis was that it would improve cough strength, which it did. So this is just evidence. We published this paper back in 2014 showing that EMST can actually augment a primary treatment, a primary surgical treatment. And so this is just showing you a cough airflow waveform pre-EMST. And so we can see, pretty big inspiratory phase rise time versus the improvement seen in the post EMST and improvements in cough compression phase duration. And so the outcomes of 4 weeks of EMST training, schematically shown here for just one of those patients, shows a significant increase in these cough measures, in particular expiratory phase rise time and cough volume acceleration, which translates to a patient having a more forceful and ballistic cough, and perhaps a better ability or greater ability to expel foreign material from the airway in a quicker manner, in a sharper and faster manner. One more interesting finding from the literature, particularly with the aging population, in a group of 24 community dwelling elders who are 65 years or older, 12 were men, 12 were female. They were utilizing EMST device 5 days a week, 5 sets, 5 breaths at about a threshold of 70% of their maximal capability. And what we saw in this group is that they also improved their buccinator and orbicularis oris muscles after the EMST. So this wasn't an initial measure that we were studying, but the conclusions of this study show that EMST is also an effective technique for older patients and has positive impacts on other swallow-related muscle functions. I want to just highlight that these techniques, whether it's inspiratory muscle strength training or expiratory muscle strength training, is not a one-size-fits-all therapy program. Oftentimes in the clinical setting, we adjust that program based on the patient needs. Sometimes we need to be less intensive in the training for a patient. I've had sometimes, particularly with my older patients, where we've had to train just to the breathing task and the cycle of breathing. And we might do that with just some tactile feedback and training maximal inspiration in and maximal expiration out without a calibrated load or without any physiological load imposed. Sometimes we have to do less days per week. Sometimes we have to work up to 25 breaths per day. And sometimes we have to modify the device itself and put different mouthpieces on. So you have lots of different options. We've been very creative through the years. And now, there's a plethora of different types of mouthpieces that can be used that's more custom to an individual's, strength. One of the things that I used to hear from clinicians is they would call me and say, we have to delay our use of expiratory muscle strength training because my patient doesn't have enough lip strength to be able to seal around the device. And so back in the day, we used to get little devices that looked a little bit like a snorkel mouthpiece that would allow us to accommodate for that lack of lip seal. So we want to be able to be working on some of those interventions. So I encourage you to think creatively and innovatively in some of the ways that you do that. We have also studied the use of training and increasing force generation of the respiratory muscles in a computational model. And so these are just some images from the results of some of our work in computational modeling, where we were able to vary and quantify the changes that occurred as a result of expiratory muscle strength training and in the velocity of airflow through the point of constriction, which is at the level of the larynx. So let's see. Sorry, this is actually a slide with videos. So I didn't highlight another case series, but we actually ran another case series in some head and neck cancer patients, and then we used some of their data and plugged it into our computational model. So what this computational model is showing that post EMST, if you look now at this particular video, a 43% or 41% increase in the magnitude of airflow at the level of the vocal folds was achieved when we were able to increase expiratory force generation. And that's exactly where you want to see that increase in magnitude of airflow so we can remove material out of the airway. We also looked at this biomechanical airway model to study the effects of airway clearance on material particles of 1 millimeter in diameter within the airway. And so we were able to look pre and post EMST in this biomechanical model by simulating penetrance traveling along different parts of the airway when it was exposed to a weak cough or a strong cough, where if it was able to mobilize and remove that material. And so this data is essentially showing you the effects of that. And probably one of my favorite things to share from data from our computational model is what happens to some of these tiny little droplets that we aspirate. And so we actually did a droplet study. And so you're going to have to like squint and lean in really close to the screen you're viewing this on. You're going to track this little a little dot. You see it on the right-hand side. I'm going to play the video here. This is actually a droplet that is moving in the airway, and it will go below the vocal folds, and the gravitational forces will have a pull on this. And in that video, what you saw, and I'm going to play that one more time, so if you missed it, you missed the highlight of everything kind of coming together. So the gravitational pull pulls that droplet below the vocal fold, but a strong cough comes along, and it actually breaks up this little droplet into what we call little child droplets so that they're small and buoyant enough to be able to be expelled out of the airway. The contrast is when we have a weak cough, which you see here on the right-hand side of the screen, and the gravitational pull pulls that droplet into the airway, and no matter how strong, no matter the cough, it was not strong enough to be able to mobilize that and even break that little droplet into smaller little droplets for it to change the buoyancy pattern and to expel that out of the airway. So I'm giving you some of the highlights of some of our computational work, but what this translates to is the translational meaning of this is reflected in airway protection. And biomechanical modeling permitted us to precisely examine some of the underlying mechanism of EMST as a rehabilitation strategy for cough. In this case, for those undergoing head and neck cancer, but it also shared with us some important data, or highlighted some important data related to cough and the importance of a cough intervention, particularly when we think back to, if you remember that slide where I showed you all those frothy secretions and the idea that these negative airway pressures can suck some of those secretions into the airway. If they're laden with bacteria and those small little droplets get reabsorbed into the lungs, this can become an important risk marker to highlight in reducing or understanding the impact of aspiration pneumonia. And last, we talk about intervention and modification of devices. Years ago, we started looking at this with a group of individuals who had laryngectomies. And so when we think about atrophy in the respiratory musculature, we think also about individuals post-laryngectomy who don't have a larynx to create a pressure gradient to build pressure upon. And so some of the symptoms that we see in some of our particularly older laryngectomy patients is really poor secretion management. And because of the loss of filtration and humidification of inhaled air, we see thick mucus secretions that can't be mobilized. We see a lot of huffing and puffing in an attempt to cough, but without a pressure head. There's no way to mobilize that. And so what we wanted to do was intervene, and we hypothesized that if we could increase the strength of the pump, we could increase the airflow velocity and hopefully mobilize some of those secretions. So what you see here is that we modified a device to collect respiratory pressures. We modified a manometer and 3D printed a little valve so we can collect that data. And then we also just inserted one of the older mouthpieces for an EMST device right into the stoma, into the base plate. And so some of you, if you've tuned in to some of our work before, may have seen this video, but it's always an exciting one to see when we apply
Inhale.
EMST device to a
And
stoma,
exhale.
and that individual is very easily able to go through that device. And so we've gone through a variety of different studies in being able to understand some of the quality of life and physiological factors that are improved in that patient population. Last thing I want to highlight is some work that we're really excited about. It's been a concept in the making for, about 25 years, as long as Chris Sapienza and I have known each other. We've talked about the application of expiratory muscle strength training and inspiratory muscle strength training in microgravity environments. So some of the same principles that we know that can impact skeletal muscles from muscle use dysatrophy can be accelerated in microgravity environments. And so I end with this as sort of our future vision as health initiatives and microgravity environments are starting, no pun intended, to take flight, to be an area of increased study and funding. We are very excited about the potential of someday being able to study respiratory muscle strength training as a pre-intervention to microgravity travel, and as individuals return to Earth as a post-intervention strategy, because of the detraining that very quickly affects the respiratory musculature and the musculoskeletal system in microgravity. So if you don't have any other questions, or if you're, I don't have any other slides, so I'm open up to any other questions. I want to end with, as this is a very small snapshot and sample of some of the cases that highlights the intervention across voice, speech, swallowing, cough, and quality of life factors.
Well, thank you, Dr. Hoffman. I am going to, again, you got a great audience. You've got a lot of questions here. So I'm going to try to get through them in an efficient way, but they're fun. So, number one is, first of all, we spend about $1.8 trillion, as a society in the US on exercise. So, I'm going to just quick comment on the prophylactic use, who pays for it. It really comes down to an individual desiring to use EMST or IMST as a way to train skeletal muscles. It's a choice. And I think what Dr. Hoffman has been describing is skeletal muscle degenerates with age. We know that. There's not a lot of ways that we can train these muscles unless we're using pressure threshold devices to do that. And she took it all the way down. You took it all the way down to the vocal fold level, right? Showing skeletal muscle decreases down the vocal fold level. Folks are concerned, I'm going to refer to you as Bari, that, EMST aggravates reflux. Can you talk about reflux? Can you talk about, you use PPIs all the time, it reduces acid, but it doesn't stop reflux. What can we do for patients that have reflux?
Yeah, that is an important question and clinical conundrum that we deal with all the time. And actually, I didn't mention this in today's topic, but uncontrolled reflux is a contraindication for us to utilize this in the clinical setting. So when that is the case, we work with our laryngology, our ENT colleagues or GI colleagues to help manage that. So there's medical interventions, there's behavioral interventions. As speech pathologists, we really work a lot on diet and lifestyle modifications and addressing that. Through the years, I've worked collaboratively with my ENT partner where we were able to get that under control in a relatively decent amount of time and be able to then begin intervention. And Chris, you may have other experiences with some other populations where you have more to add to that answer.
Well, I was commenting, a lot of people can see the chat, Bari, and I know you're busy talking, but not for this talk, but folks know that when you're using inspiratory muscle strength training, so in inspiratory, the diaphragm's going to pull down, and that's going to exercise your lower esophageal sphincter. So we typically, if somebody's got an uncontrolled reflux and it happens to be coming from the LES, which again is going to weaken with age, then an IMST protocol is going to be applicable. And I'm happy to take questions on that after to my email. Bari has her email. We can direct questions to her, but that's almost a whole different talk. We do know that for some patients, doing EMST can aggravate reflux, but if the patient's on PPI and we're reducing that acidity, we just have to monitor. We have to look at patient report and whether or not they're feeling uncomfortable. We list it, Aspire lists it as a, potential comorbidity, but it is, something you have to keep a clinical eye on. But in all the years that we've been doing this, it's not something that has screamed out at us as a big problem with patients training on these devices. Bari, another question is, we all know through the neurophysiology literature that if you stop using the muscles, you lose it. So therein comes the detraining. You showed a whole bunch of different patient types. What's working for you clinically and as a maintenance protocol? Because it hasn't been researched. Can you tell folks what has worked for you clinically for maintenance?
So, yeah, and again, we haven't studied this. This is all anecdotal. First and foremost, we're going to take anything we can get from our patients. So, once a week is better than 0. We typically try to get them doing that 2 to, we encourage 3 times per week. If we encourage 3, we get 1 to 2 times. People go on vacation, they forget, but that's typically what we are asking individuals to do. I will tell you, we say a minimum of 2 to 3 times a week. We have some patients who just continue doing it. It's part of their regimen. It's what they feel. And I think some of it is, kind of, their mental health preparation for the day, and they do their exercise, they do their stretching, they do a variety of different vitamins, they follow certain dietary restrictions, and that sort of sets them up. And so we have many patients who just want to continue training at the 5 days a week.
Yeah, so the bottom line is obviously more is better, but we all know us, right? And people tend to have a problem, getting to the gym with that frequency. Unfortunately, and I think it's a point as clinicians you should know, there isn't a lot of detraining literature out there as a function of disease. So we don't know how fast a patient with Parkinson's disease or, ALS, et cetera, spinal cord injury was brought up, Bari, on the chat. We don't know how quickly they detrain. So we have to put them into some maintenance protocol. And we feel that 2 to 3 times a week is doable for individuals. But yes, you have to counsel your patients that they will go back to baseline if they put the device down after 5 weeks. And studies were done, and we have so many great outcomes on the 4 to 5 week treatment protocol, but we only stopped at 4 to 5 weeks because it was research. The exercise, strengthening, endurance all has to be continued for longer periods of time. And I think when, going back, Bari, to the question about, ROI, price of the device versus outcome, I always get so blown away by that image that you did when you modeled cough and you showed, that strength of cough is so much related to airway health. Can you expand a little bit more about what you're finding with cough and EMST and why this seems to be such a big deal in the literature?
Are you talking about the model?
Yeah, the model. Mm-hmm.
Well, yeah, that whole body of work, I think was probably one of the most exciting things. We were able to demonstrate things that we thought were happening, and then to be able to manipulate some of the parameters, like the stickiness of the airway, the tracheal wall,
Mm-hmm.
and being able to manipulate different pressures with different consistencies, whether that is droplet of different sizes, different buoyancies, or material that we know individuals aspirate. So we were able to take material and place it at different points in the airway and then manipulate a cough at different strengths and to see what was, it's almost like a dosing. It wasn't a dose study, but it was almost giving you, some ammunition in that regard to be able to show if the cough strength is at, certain level, it's not going to move this material out of the airway, or it's going to get it to maybe just at the level of the larynx, but then it gets the gravitational forces pull it down into the airway. So I'm probably making that a little more complex than it needs to be. But I think what it did is it just optimized what we needed to know and gave us more ammunition to talk with the physicians and talk with providers who are going to be referring patients, that there is something that we can intervene with, something very easy, tangible, and with short duration, that we are able to help that individual protect their airway and simply by increasing cough strength.
So, the take-home message then, and I'm reflecting back on your early comment about watching your mother age, it's really a decline then from what you're seeing in older patients, not just a pulmonary decline due to, reduced lung compliance and reduced muscle strength, but those vocal folds are not able to contract as much, right? So is that what's creating the poor airway management?
Well, I think it's a combination of all of those factors. It's a multiplier effect. So I think it's important clinicians need to evaluate, is it just weak respiratory drive? Is there poor laryngeal valving? Oftentimes you got to intervene at both levels. Sometimes increasing of the pressure head can help improve closure, but sometimes that glottic gap is just too large to achieve with just pressure alone. So working, in an interdisciplinary combined modality management model, really elbow to elbow with your physician partners is going to be ideal.
Yeah, that's well said, and you've done that for so many years. I think for the audience perspective, it was a great review of what is happening with aging. I always say that, if you look at the literature today, we are aging very well as a society. That means we're living longer, but we still have to be proactive in exercising the muscle systems, just like we have to exercise the cognitive system, right? And that old adage, you can't teach an old dog new tricks, I think actually isn't the case. The old dog can learn new tricks, and the old dog actually is a plastic dog. It will adapt, it will modify itself, and the literature is showing that the muscles can be rehabilitated and can be strengthened regardless of age. And so that's why we as clinicians, both from a cognitive standpoint as well as from a muscular standpoint, need to be actively working with our patients, because at some point, not only will they age, you may have that layer of disease that goes on top of that aging process. So I think you elucidated that really well with the cases. You showed that across, somebody with head and neck cancer, somebody with paralysis, your work on Parkinson's disease. You've covered the gamut in your career. So I just wanted to give you the last 5 seconds if there's anything you want to say to the audience as a take-home message, and then thank you very much for your time this evening.
Well, thank you. It was fun getting a chance to talk about this. I think take-home message is, the application, the prophylactic application, and being sort of speech pathologist, can really be the champion to highlight this and to suggest this and socialize this within our healthcare and medical communities.
And I have to ask you one last question that just came in. I know some folks have to go, but did you wait a certain amount of time after they augmented the vocal folds so that, you weren't using maybe EMST right after? Can you tell the audience how long you guys waited?
Well, for the vocal fold augmentation study, we did wait. We started EMST 2 weeks after. 2
weeks. Okay. That was a great question by one of our audience members. So 2 weeks says Dr. Hoffman, who's been working in the ENT field for 25 years. Thank you, Bari. Thank you, Dr. Hoffman. Thank you, UCF, for letting you go for an hour. Thank you, Aspire Products. We'll see you again last Wednesday. We're already in the month of March, so we'll see you in April. Thanks, everyone. Keep an eye on emst150.com for information about further presentations. Take care. Bye-bye.